This is Dr. Andrew Young over at St. John's, Santa Monica at the Center for Knee Replacement, and today we'll speak a little bit more technically, specifically talk on robotic-assisted partial knee conversion to total knee replacement with tibial augments. And we're going to focus on three main concepts. One is how we deal with retained hardware and look for impingement to know whether we need to remove or whether we can retain hardware. Number two, how we deal with bone defects. And three, how we plan for the level of augmentation. So this is going to be more technical for those of you who are interested in this level of detail. Okay, so we're starting off with a relatively complex situation. This is looking at it from the front, or the AP, and this is looking at it from the side. And here we're dealing with a patient who's already had two sets of procedure. A younger patient had a prior ACL, two-stage technique with a femoral screw and staples holding the graft, and you can see the graft tunnel right here. So ACL, and then went on to develop medial compartment arthritis at a later date and had a secondary partial knee replacement. So this patient has had a long history of post-traumatic change, first starting with a blew out ACL with a subsequent repair, then went on to develop post-traumatic arthritis in the medial compartment and had a partial. But now, even later, is developing opposite compartment degeneration. We can see the lateral start wearing out with some subluxation to the side. So we're going to work on converting this, and we have three main problems. We have hardware, a femoral screw, and two tibial staples. We also have hardware here in the partial knee replacement. We're going to have a bone defect, and then we're going to need to figure out how to restore mechanical stability, both in the femur and the tibia. And we'll walk through those processes. The first thing is stepping back and then getting a model of the knee. So we'll get a CT scan, and then we'll make a three-dimensional model of the knee and the alignment of the knee. We'll first start looking at the femur. And when the femur, we're looking at the anatomy of the femur, the position of the implant, and the position of the retained hardware. So the screw is up here. And we can see the screw is very out of the way of our total knee replacement. So we won't have to make a secondary incision to get this out because this is not going to impinge or affect our knee replacement. Okay, then we'll look at the knee itself, and then we can plan the sizing as well as the positioning. And so we can see that we're within the bounds of the medial and lateral condyles. We'll look at our rotation here to make sure that we are neutrally rotated in relation to our surgical epicondylar axis, and typically that works about 3 degrees externally rotated to the posterior condylar axis, and then we'll look at our overall symmetry, anterior and posterior offset, to make sure that we have the right sizing, alignment, and positioning. Then we'll go to the tibia. In this particular situation, management of the tibia is going to be more complex. The first thing is these staples are in the way. We can see the staples here are impinging on the keel of the tibia. So these staples, unlike the screw at the femur, these staples need to be removed. So we're going to have to go after these screws. The second thing is we can see when we bone map this out, the level of the current tibial implant is below the predicted level of where we will place a neutral tibial knee replacement. And then there's a little bit more defect that extends beyond that. So we're going to have to get to the level of these dots that where we mapped out healthy bone. And so when we look at it from axially, we can see this is the appropriate size. We can put in the proper rotation, but when we look from the side, especially on the medial side, we can see this is where a standard implant would go, but we're going to have all this defect that we need to manage. I'll show you how we manage that defect. Okay, the first thing that we do is that we visualize where we will place our component on the bone itself. And we're looking first at the femur, and we can see there's a tibial implant here. We've looked at sizing, we've looked at rotation. We will then remove this implant and then map out the remaining surface of the bone. So this is the lateral side. We took off a medial implant, so we're going to map out the medial surface of the remaining bone. And then we will adjust our implant so that it is resting on healthy bone. And so you can see here's the remaining bone. The implant has been adjusted so that it goes below the level of that defect into an area of healthy bone. So the femoral component will be resting on healthy femur. Nice thing about this is that all this can be visualized virtually prior to the implantation of any permanent components. Now again, the management of the tibia is more complicated. So we're going to have to remove these staples, but the hard thing is that we're dealing with this defect on the medial side. So we typically place the lateral component at 8 millimeters of lateral component. But when we do that, we can see we're going to have defects, so this tibia will not be resting on anything solid. So once we place it here, we want to measure how much defect this actually is to get to healthy bone. And so we'll drop our tibia down to we're just past this, and we can see it moved from 0.5 to 4.5. That tells me I have 4 millimeters of defect on the medial side. Now that drops me to 12. I can't just make a straight cut because I'll be sacrificing too much healthy bone on the lateral side. So I know we want to plan for 8 millimeters here, but I know I have to drop this at least 4 millimeters to get to healthy bone. Now augments come in 5 and 10 millimeter increments, so I'll drop it to 5. I'll take 1 additional millimeter on this side so I can get to healthy bone. So over here we'll cut 8, and over here we'll cut 5. So we'll do this in 2 separate stages, and I'll show you how that's done in real time. Okay, so what does that look like in real time? So this is the femur. We're looking at coronal, we're looking at axial, we look at sagittal, and we're going to do the same thing with the tibia. The femur was relatively straightforward because the screw was out of the way and we didn't have any major defects. We could rest our component on solid bone. But the tibia was very different because we had hardware we needed to remove, and this tibial implant extended below the surface of where a natural tibial implant would sit. We calculated that at 8 millimeters of lateral resection, we would have 4 millimeters of defect. But because these come in 5 millimeter augments, we need to drop this to 5 millimeters. So I'll show you what that looks like. So we're at 8 millimeters. I have 0.5 on this side. I'm going to drop this 5 millimeters so it goes to 5.5. Now I'm 13 on this side. I'm not going to cut 13, I'm going to cut 8, but I'm going to drop this to 5 after I made that cut, and then I'll bring it back up to 8. So what does that look like at the end? So this is what we started with. We had a femoral screw, we had 2 staples, we had an ACL tunnel, we had a medial, femoral, and tibial component, and we had an associated bone defect. When we looked at the CT scan, we were able to know ahead of time that this was not in the way, so we wouldn't have to make a counter incision over here to take this out. That was out of the way. However, these 2 staples are in the way, so we had to go after that. We were able to take out this femoral component, but there was very little bone loss, so we could just rest a natural tibial component on healthy bone. This tibial component was more difficult, so we took off 8 millimeters on this side, but then I had to drop an additional 5 millimeters to plan for this 5 millimeter augment right here. So you can see the natural tibia goes here, but I had to create another 5 millimeter augment so I could rest this on healthy bone all the way across. And now I have a symmetric extension gap and neutral alignment. So that was a brief case study on how we use technology, specifically CT scanning and 3D modeling, to get an idea 3-dimensionally of presence of hardware and whether it will impinge or not impinge, the placement of retained implants, possible bone defects, and then how we can compensate bone defects by adjusting the level of cut and then using metal augments to replace areas of bone deficiency. All these concepts were concepts that we used to use when we did conventional partial knee replacement conversions, but they're so much more precise when we're able to quantitatively and mathematically make these calculations using the power of data and computers. Thank you.